Hello, everyone. I know people are still trickling in, but I thought we should get started. Thank you for coming to our 5th annual Grand Rounds during Midwifery Week. We're really excited. We have a wonderful speaker this year. Well, we do have one piece of business to do first. And Jennifer Hirsch is going to have the honors.
Do you all know what this is? This is a fetoscope, and this is the Thomas More Midwifery Partnership Award. Jennifer,
Microphone.
oh yeah. So the Thomas More Midwifery Partnership Award is given each year to the attending physician who, in the style of Dr. Tom Moore, whose vision and brilliance it was to support midwifery at this hospital, not only within the context of labor and delivery, but also supporting the birth center and women having choices. So we give this award in honor of Dr. Moore, and we give this to the attending who has really helped us with our patients and supporting the birth center. This year, this award is being given to an attending for several reasons. In no particular order, I've had patients that have transferred to midwifery care after mentioning to this doctor that she would like to have an unmedicated birth, and without even knowing about the birth center, the patient didn't know about the birth center or the midwives, but this doctor said, oh, you should transfer to the midwives because they have a birth center. This doctor has also helped us out. We have some patients who were a little reluctant to get certain testing done, and she has helped us out a great deal with offering these patients an objective, rational and thoughtful information to guide their choices. They don't always change their mind, and they're not always thrilled about getting the testing, but they always say that they feel that they've been heard and respected. Was there anything else I wanted to mention? Anyway, we love this doctor. Dr. Sandy Ramos, thank you very much for being so supportive. Dr. Moore was very excited when he saw this because you actually have to touch a patient to use this in labor. You put this down and you listen.
Oh my God, I love it. Thank you. Thank you so much. Okay, so without further ado, Dr. Erin Caughey is Professor and Chair of Obstetrics and Gynecology and Associate Dean for Women's Health Research and Policy at Oregon Health and Science University in Portland, Oregon. His medical training was at Harvard Medical School, and he completed his residency at Brigham and Women's Hospital in Massachusetts General. His fellowship in maternal fetal medicine was at the University of California, San Francisco. As faculty at UCSF, he served as Director of the Diabetes and Pregnancy Program, Director of Perinatal Research, and Director of the MFM Fellowship. His research is focused on examining clinical questions related to complications of term and preterm pregnancy, gestational diabetes, and prenatal diagnosis, and has led to more than 250 peer-reviewed publications. In addition, as a singer, he sang with the Back Bay Chorale in Boston and the San Francisco Symphony Chorus, earning 2 Grammy Awards. So I'm thrilled to introduce Dr. Caughey.
That's kind of you. Yeah, I guess I should take the Grammy Award thing off my CV. It just feels like kind of an odd thing to brag about. You know, I was, one guy in a row of 100 people. So, but it was an incredible honor to get to sing with Michael Tilson Thomas and the San Francisco Symphony Orchestra for a number of years. All right, here's the switcher. So thank you so much for inviting me. I mean, it's an incredible honor to be invited. I mean, I get invited to do resident research days, and that kind of makes sense. But to be invited to participate in a profession that I'm only next to but not part of is a real honor, and I really appreciate that. This talk, actually, a very early version of it, I gave at the ACNM 4 years ago on the invitation of Caughey King, one of my partners at UCSF. I think it's evolved quite a bit since then. And the problem with this talk in a midwifery-focused crowd is I don't have much to teach a midwifery-focused crowd, because you're already like, yeah, that's what we've been doing for 30, 50 years. I mean, like, yeah, come on, doctors, let's go, right? So I appreciate that, but to be fair, you know, we're slow physicians, but hopefully we're going to slowly catch up to where you've been all this time. So disclosures. I have no financial disclosure related to this talk, but I will say that I'm a medical advisor to these two companies. These are prenatal diagnosis companies. We don't think we're going to have a prenatal diagnosis test created to figure out predicting C-sections anytime soon, so I don't think I'm truly conflicted. This company does do some fetal monitoring stuff, but I don't actually really talk about fetal monitoring today. Now, Bob's Red Mill. Do you guys know what Bob's Red Mill is? Do you shop at like Whole Foods, New Seasons? Yeah. So Bob's Red Mill makes wholesome grain goodness. Muslix, granola, that kind of thing. So Bob and his wife Charlie donated $25 million to OHSU to create the Bob and Charlie Moore Center for Wellness Nutrition. And I serve on the leadership committee, the steering committee for that organization, and was one of the co-investigators on the first funded grant to that organization. So I do feel like it's appropriate for me to acknowledge Bob's Red Mill, because it's a private company. And I will really truly refrain from talking about wholesome grain goodness for the rest of this talk. My other disclosure is that I am biased, because these 4 children, we believe are mine. 2 of them actually kind of look like me, like they all kind of do. So, and they were all delivered vaginally. So I am biased to believe that actually vaginal birth is a reasonable way to have children, which, you know, makes me biased in one direction. I haven't experienced a cesarean birth, so, you know, that obviously provides a bias. And my wife, who's featured right here, was a residency classmate of Dr. Sandy Ramos for 4 years. So it's an incredibly lucky thing to be here on a day where she's awarded a midwifery consultant award. I will point out that Sandy and Susan trained at a Kaiser that had no midwives. And so it is never too late to learn how to work across the aisle, or, you know, with our partners in midwifery. So this talk is we're going to talk about C-sections. We're going to talk about the morbidities, why we care about C-sections. But we're going to talk a little bit about why the C-section rate has risen over the last 15 to 18 years. And then we're going to talk about how we might walk backwards through time and lower the C-section rate back to, I'm not talking about the early 70s, but maybe back to the way it was in the early 90s, like 20 years ago. Right? So as we all know, the cesarean delivery rate was 32.8% in 2011. The 2012 preliminary data is out, and it's looking like it's going to be flat. And this is actually the first time, you know, this year is the first time I can give this talk and I can say this was a decline from 2010, because as you know, in 2010 it was 32.9%. So actually it is beginning to decline by 0.1%, right? But at least it's not going up, because remember, from 1996, and I'll show this slide, from 1995, 1996 through about this year, 2007, I mean, it went up about a percentage point every year. And 1 percentage point in our population, 4 million births a year, right? So basically that's 40,000 more C-sections a year, every year, 40,000, 40,000, 40,000, right? So how do we walk backwards through time? And this is around the globe. This paper was published in Birth about 2 years ago. Jean DeClercq, you're probably all familiar with. Jeff Becker is a bit of a national mentor to me, currently at Mass General, was senior author. And you can see, here's the US, and we have that familiar curve that we're used to seeing, that we went down, we came up. Notice that no other developed country, which is pointed out in this paper, has ever done this, gone down. No other developed country has actually ever lowered their cesarean delivery rate. Now you can point out, well, gosh, in the Netherlands they never needed to, because look at their C-section rate, it's, you know, lower than ours, right? Or Norway, right? So, well, okay, good point. But still, we've been able to do it. Nobody else has. Here, look at Italy. We were number 1 back in 1985. We were 25% in this country, 24% actually, and we were crushing the competition, right? I mean, the closest country was, you know, Italy was 15%. But, you know, we are now not number 1 around the globe, and so countries like Italy, I mean, this is the national rate, is 40%. In parts of China, in Beijing, for example, in an insured kind of population, the rates are in the 70 to 90% range. In Mexico, for example, in the insured population, it's in that 50 to 80% range. I was told in Mexico, the insurance companies don't reimburse for vaginal delivery because, well, vaginal delivery just kind of happens. That'd be like reimbursing for, like, having a cold or something. It's something that happens biologically, naturally. So they only reimburse for cesarean deliveries. So I would call that a perverse incentive, right? So, I mean, if it requires care, then we should be paid for it, to be fair. And so all that has led to an interesting changes around the globe. So why do we care? Now, I would suggest that even if cesarean was as easy as beam me out Scotty, right? You pull a lever and the baby would magically appear outside the womb, we would still care. There are still things that occur during labor that are beneficial to the baby, okay? But at least if we could do that, we wouldn't end up causing as much harm to the mother. So maternal morbidity and mortality is simply higher with a cesarean delivery as compared to a vaginal birth. You can't have a surgical site infection if you don't have a surgical site. Okay, that common sense. We make this giant hole in the uterus, an organ that wasn't really intended to have giant holes made into it. Okay, now the average blood loss after a vaginal delivery, we think, is about 350 cc's, and we call it a postpartum hemorrhage if it's above 500. Right? What's the average blood loss of a C-section? Somewhere between 800 and 1,000. So essentially, by doing a cesarean delivery, we intentionally cause a postpartum hemorrhage. Now, we don't call it that. We only call it if it's above 1,000. But technically, in terms of the biology of our species, it's a postpartum hemorrhage with every birth, right? Then we start, injuring organs that are nearby, the bladder, the bowel, the ureters. Now, this generally doesn't happen with primary cesareans, but certainly you start doing more, it can, and even with primaries. Postpartum, we get a higher rate of DVT and PE, and this is where we really start getting some morbidity and mortality. So Steve Clark showed, this is a paper from about 4 years ago in the Gray Journal, about a 10-fold increased risk from a cesarean delivery versus a vaginal delivery, and even if it was a scheduled repeat cesarean, about a 5-fold increased risk. Okay? Now the problem is, you say, well, wait a minute, hold on. This could be confounding by indication, right? So women have cesarean deliveries are often as more complicated patients, right? So someone who's got severe preeclampsia is going to have a higher C-section rate than someone who comes in term labor, right? So what they then did next was they looked into the cause of those C-sections, and they found that even though the total, when it's actually related to the mode of delivery, was lower, the relationship is the same. It's a 10-fold increased risk of dying from the C-section as compared to from vaginal delivery, and it's a 5-fold risk from a repeat C-section. Now, the number needed to treat is high, right? This is per 100,000, right? So you've got to do 50,000 C-sections to cause the woman you're caring for to die, right? That's a pretty high number needed to treat. I would suggest none of us in the room will do 50,000 births. Dr. Resnick may get close, right? But most of us are not going to do 50,000 births. But collectively, if we do 2,500 a year over 20 years, one of those C-sections is going to have causally caused the death of our patients, who don't die very easily or very frequently. They're young, healthy women, the most of them, right? So this is a big deal, I would suggest, and we should care about this. So that's in the current pregnancy. What about subsequent pregnancies? Well, in subsequent pregnancies, there's all kinds of risks that we don't actually counsel our patients about when we're doing that first C-section. So the first is the subsequent risk for cesarean delivery, right? Well, we showed in that slide the VBAC rates, right? VBAC rates in this country are currently about 8-9%. And in some hospitals, many hospitals in California, it is 0, right? So if you're in a hospital where they don't do VBACs, then you can say to the patient, once a cesarean, always a cesarean, right? Because they don't have any other options. And you say, well, wait, no, they always have options, right? Even though you're living in Crescent City, California, you can always drive down to San Francisco for your VBAC. And when I was at San Francisco, that's what our patients would do. They would drive 4.5 hours. They would live in some small, the prices of motels and hotels in San Francisco is ridiculous. So they live in some small motel that was only $100 a night and wait to go into labor, right, for a week, 2 weeks. I mean, these are committed women because their alternative option up in Crescent City was what we call the home back, which I'm sure you've heard about, which is a home VBAC. Now, most of those go pretty well, but as we know, 1 in 200 to 1 in 400 of those will end up in a uterine rupture. Now, if you rupture in a hospital, we can get the baby out pretty quickly. If you rupture at home, the outcomes are not as good, I would suggest. So cesarean delivery, it's going to be a high probability of a recurrent. There's a really nice paper from Gordon Smith that would suggest that women with a prior cesarean have an increased risk for stillbirth. Now, this doesn't happen at a population level, because if you have a prior C-section and you get scheduled for your repeat section at 39 weeks, you can technically not have a stillbirth at 40 or 41 weeks. So you actually have, on average, no difference. But on a bi-week basis, the risk of stillbirth is increased by 20 to 30%. So the risk of having a 37-week stillbirth in someone with a prior C-section rate is about 20 to 30% higher than someone who's had a prior vaginal birth. Really nice paper by Gordon in The Lancet in, I think, 2003. Obviously, uterine rupture. So what's the risk of a uterine rupture in someone with no prior C-sections? You guys know this? It's about 1 in 20,000, right? Really rare, right? 1 in 20,000. What's the risk of a uterine rupture in someone with a prior scar? About 1 in 200. So that would be an odds ratio, or a relative risk of 100. Think about the things in medicine that you can think about where the relative risk of a causal thing is 100. Right? We get really excited if we get an odds ratio that's statistically significant and it is 2, right? You've increased her risk of having a uterine rupture 100-fold by making that hole in the uterus. So I suggest that we have to make some holes in uteruses, right? It actually, when you go from a 0% C-section rate to a 10% C-section rate, you prevent neonatal and maternal morbidity and mortality. We got to make some holes. But I think we maybe should take it seriously when we do it, because 100-fold increased risk. Now, we all know about this. We increase the risk of abnormal placentation, previa, accreta, hysterectomy, and this then is the other cause of future maternal mortality, is these women simply bleed to death when we're trying to get the uteruses out because they're pouring out 300-400 cc's a minute, right? This has been shown by Bob Silver, as you know, and this would be kind of number of prior cesareans, incidence of previa, number of prior cesareans, incidence of accreta is almost exponential. This is, there's old data on this from Clark as well. There's no question about this association. In the British Journal, I apologize for not adding this to the slide. I was thinking about updating my slides, and I sent them to Lizette before I added this. In the British Journal in June of this year, they showed that women who have a scheduled, unlabored C-section as compared to a labored C-section have a 3-fold increased risk of previa and accreta, right? So it's those scheduled C-section without labor that increase the risk further. Another good reason for someone to have a trial of labor after cesarean. At least if you labor but you fail, you don't increase the risk of accreta quite as much. Okay, so we definitely find this association. And why do we care about accretas? I mean, look at the difference in morbidity between accretas and previas. 94% end up with hysterectomy versus 0 in this relatively small study at one institution, our institution. 42% end up with cell saver. 1 in 3 end up in the unit. 1 in 8 have a surgical injury to ureter, bowel, bladder. Now you say, well, gosh, not in my hands. I've never tied up the ureter. Well, you do enough. You're going to need a bag of ureter or two when you're trying to get that uterus out really quickly. You say, well, that's because, it's MFM's doing it. Why don't we have the oncologist do it? Well, okay. We can get into that discussion, but the bottom line is there's more injury, okay? We looked at this. So Carla Solheim, who's a third-year resident at Iowa now, and all these other cast of characters, Tanya Esikoff's now at Cedars, Teresa Sparks and Sarah Little are both fellows. We built this giant model to figure out what was going to happen. We built this in 2006, or 2007 using 2006 data. Say, well, if this C-section epidemic continues, what's going to happen downstream? Why did I care about downstream? Because the C-section today leads to the repeat 92% of the time in 2 to 3 years, which leads to the three-peat and potentially the previa accreta in the three-peat or the four-peat, right? So it's downstream, 8 to 10 years down, that we see the lag. Oh, that just went backwards. I'm not sure why. Let's go forward. There we go. And so what we said is in 2006, we estimated there were about 600 maternal deaths in this country, and this many previas and accretas and cesareans, okay? By 2010, assuming that the rate would continue about a percentage a year, we got 24 maternal deaths and 76 in another decade because of that lag effect, right? The C-section you do today, repeat, previa accreta, right? Even if there was no increase at all, we had stopped in 2006, which was at that point like 29%, even if we leveled off, you still would have 20 more maternal deaths in 2020 from the lag effect. Even if we slowly go down, it's only if we slowly go down that we'll actually start seeing a decline, okay? And what did we see actually happen? We saw the same increase 2006, 2007, 2008, 2009, 2010. Finally, in 2010, we've leveled off, but basically we've got that increase until 2010, and now we're going to have this lag effect downstream. So that lag effect will lead to 50 more maternal deaths. These are, we believe these are going to occur, right? Unless we somehow figure out the regionalization stuff. But, in a big state, rural state, like Oregon or Montana, it's really hard to get these patients to the hospitals that can take care of them. We just had one about a month and a half ago. She ended up with 184 units of products. Only 84 RBCs, but, FFP, platelets, 184 units. It drained our blood bank, right? So there's one other hospital in our state that she would have survived at, I believe, but no other hospital would she have survived. So this matters. We think this matters. I would suggest this matters. I'm preaching to the choir here. You guys think this matters. So let's move on. Why have they gone up then? Why have they gone up? Are we improving outcomes? Why have they gone up? Well, some people would say it's the women. The women are changing, and it's the women, and that's why the C-section rate's higher. Some would say it's really the women. The women want the C-sections. We're honoring, aren't we pro-choice? Aren't we pro-choice? Maybe not in this county, I don't know. But if you're pro-choice, right, you want to honor their preferences. We believe in patient autonomy. We're giving them options. They want the C-sections. We're honoring that choice. Maybe. I would suggest there are other things going on, and we'll talk about some of these data, okay? So what about the characteristics of the women? It is true there are more women over the age of 40 having births today in the United States of America than any other time in the past. But if you look at it, the data stratified by decade, the C-section rate is going up in every group. Every group it's going up. So it's not just changing maternal age. It's not just race ethnicity. Yes, Caucasians are no longer a majority group. They have been in California for a few years now, but even in the US, doesn't matter. Every racial ethnic group, it's going up. Every BMI subgroup, it's going up. Every level of parity, it's going up. Okay, so it's not just patient characteristics. But maybe it's the women want them, right? Maybe it's this beautiful CDMR that's come up. So I'm not sure, you can pronounce VBAC as easy, right? I know CDMR is maybe like Cudmore or Codmore. I'm not sure what it is exactly, but CDMR, which is not easy to say, but that's elective C-section, right? And we don't say elective C-section because people have elective repeats. We don't mean that. We mean a cesarean delivery on maternal request without an indication, okay? And Joe Wax wrote this paper about almost 10 years ago now and said this might be as much as 1 in 6 of the C-sections we're seeing, right? Now, how did he do this study? Took vital statistics data, and if they didn't have a coded indication for the cesarean, he said, well, that could have been, right? Well, that's probably not that true, to be fair. We don't think it's anywhere near this. How many people, I assume the midwives, none of you have done elective C-sections, you probably know cesarean privileges, but of the doctors, how many elective C-sections have you done in the past year? Has anybody done any? Right, so and we're so we got one, right? Have you done more than 5? You've done more than 5 in the past year. So it could be just the one guy, right? It could be just that. But we don't think so. No, you're right. You have to do them. I know you're on L&D 4 days a week, so I understand. So right, so it's not 0. I wouldn't say it's 0, but I think that it's probably not even 4%. Even in Southern California is considered a hotbed, right? Britney Spears, Madonna, right? So Manhattan and Southern California are considered hotbeds. Even in those two parts of the country, I don't find the doctors that are doing all these elective C-sections. There are some, of course, but it's not 4%. It's certainly not 18%. So the NICHD convened about this in 2006. They said, you know what, we should look at this. We should figure this out. There's still very little data. Around the globe, the C-section rates they vary. And we found that they were quite high in Chile. So we went to Chile to ask women. Now, to describe the care in Santiago, Chile, there's basically 2 modes of care. One mode of care is private practice doctors. You have either insurance or you pay out of pocket. Kind of like Manhattan, right? You just you go in, you get a 4D ultrasound, you give them $200 or 20,000 Chilean pesos, okay? And then the midwifery practices, which are public health hospitals, the C-section rate's about 8%, right? So those are the 2 different populations we studied. And we found, lo and behold, there was absolutely no difference in preferences by these women. These women couldn't be more socioeconomically different, right? They have the range that you see in the U.S., right? They're like the rich people in the U.S. and the poor people in the U.S. That's about as wide as it gets in the globe, right? So yeah, 80% of these women said, I would like to have a vaginal birth. About 10% would say, I'd like to have a C-section. Many of these women had prior C-sections, to be fair. And about 10% said, I'm not so sure, okay? Interestingly, we had these women send us cards about what happened in their modes of delivery. And we'd have a lot of women in the groups that were seeing private practice doctors send back, well, I got preeclampsia, so I'd have a C-section. Or they did an ultrasound and the cord was wrapped around the baby's feet, so I had to have a C-section. Now, the thing about the practice style that I didn't tell you is that it's generally solo practice in the private world in Santiago, meaning that I have a shop, you come and see me as a patient, and I make a deal with you, I'm going to deliver your baby. But lo and behold, there might be times of the year when I'd like to actually take a vacation, right? And I didn't make a deal with you and then my friend will deliver you. The deal was I will deliver you. So there's a lot of incentives, if I'm working 365 days a year, for me to figure out ways for you to have a cesarean delivery, to be fair. I'm not sure how blatant that is, but those are the incentives. We looked at this then in San Francisco. I got a grant from the Robert Wood Johnson Foundation to study this. We surveyed 620 women, and we found that even in nulliparous women in San Francisco, now to be fair, some of these women had twins and some of them had fetal anomalies, 7% had a stated preference towards cesarean delivery. So it isn't zero, right? But here are the women with the multips. These are interesting. Prior mode of delivery vaginal, 100% of them stated they would prefer to have a recurrent vaginal delivery. Prior C-section, 40% of them stated they have a stated preference towards a VBAC, towards a vaginal delivery. What's the VBAC rate? 8%. Are we meeting women's preferences? I don't think so, right? So, I think this data on the multips is actually more interesting than these data. So what about that medical legal environment? Well, Bill Groban was a co-author in a paper by this guy, Dr. Murthy, who's actually a neonatologist who's been working with Bill. And they showed a lag effect between as malpractice premiums rose, they saw a 2 to 3 lag effect on the primary cesarean delivery rate, right? A direct association. There's a paper that came out in Medical Care. These are a group of attorneys. You always got to be a little wary of that, right? But Michelle Mello, who's a JD MPH, her appointment is at the Harvard School of Public Health. So, you feel a little better about that. So what they showed was in states that have caps on damages, there are, do I have a little bar? Yeah. There are higher VBAC rates, and there are lower total C-section and lower primary C-section rates. So that the policies related to tort seem to matter. Okay? The reason we found this paper is I had this resident who was just applying to MFM fellowship at the time, and we wanted to look at this. And I was like, oh, somebody already did it. I said, well, you know what? Did they look over time? No. So we looked over time. So these are data from NCHS, the National Center for Health Statistics data, from 1990 to 2005. And we found this. In 1990, there was no difference between the states with the caps and without the caps. And then what happened from 1995? Remember what happened? We lowered the C-section rate in this country. And as you'll see, in the states that had caps on non-economic damages, there was a greater lowering of the C-section rate during that time period. And then over the next 15 years, we saw a parallel rise, but then it really started picking up in the states that have no caps, right? It seems like medical and legal environment matters. Here's a study that Dr. Chang, I think this is in press, in Journal of Maternal Fetal Medicine, Neonatal Medicine. It was rejected. Says the Grade Journal because it was an abstract in the Grade Journal, SMFM Grade Journal. So it was just in press in Journal of MFM. So we surveyed 1,500 members of the AMA who were either OBs or family medicine doctors that did obstetrics. And we asked them these, so we created this, what we call the cesarean propensity metric. And this was 10 different cases, and you got to reply about whether you'd be more likely to let them labor and try for vaginal delivery or have a C-section. And include someone with a prior C-section presents to your office, and if you were, you section them all, then we would say you have a greater cesarean propensity, right? If you have someone who has, a breech, if you would try to avert them, then you're more likely to try for vaginal delivery. If you just section them all, then you have greater cesarean propensity. Kind of makes sense, right? So we asked them if they'd ever had a lawsuit filed against them for an obstetric-related case. And if you did, you had a greater cesarean propensity. We asked them if they worried about being sued. And if they thought about it every day, you had a greater cesarean propensity, right? If you thought about it rarely, you didn't. Now this is interesting. If they were in a state who had caps on non-economic damages, there was no difference. Now why is that? Well, we think, because the answer was, if you answered did not know about whether your state did or have caps, you had a lower cesarean propensity, which again goes to this kind of what we call an availability heuristic in behavioral economics and cognitive psychology. That when you're thinking about stuff, you're more likely to do that stuff and respond to those incentives. So for the clinicians who simply don't know what it is like in their state related to the medical legal environment, they're just busy practicing obstetrics, right? They're less likely to do C-sections. Yeah, interesting. So we think environment matters. We think incentives matter as well. So I'm an economist, and I will tell you that on the first day of my first course in microeconomics, they said, as a reminder, economics, microeconomics specifically, is not the study of money. That's a little bit like macroeconomics, and it's the study of the allocation of scarce resources. And what do we do throughout the years of taking economics courses? We're always trying to optimize utility. We say that human beings are these people that try to optimize the utility based on their constraints and their inputs. Money ends up being utilized a lot because it can be traded for things, right? You can trade money for stuff, and that stuff makes you happy. So we end up thinking that's about money, but we think it's about incentives. It's what makes you happy. And I would suggest that anybody in this room has enough money. Now, I know you're not paid what you're worth. I understand that. Your friend is an iBanker on Wall Street, and you're like, that guy makes a $2 million bonus, and I'm making, whatever I'm making. And right, you're not paid what you're worth. If you're in this room, I know you're not paid what you're worth. I appreciate that, okay? But I would also suggest you're paid much better than the rest of our country and the rest of the world, right? We're pretty comfortable. When was the last time you didn't have enough food to eat, right? I mean, if you can't say last week, you're comfortable, okay? So we don't need more money, but what do we need? We could use some more time, right? That's our biggest scarce resource, is time, right? Spending time with your kids, spending time with your partner, downtime to sit and think about your next research project. I mean, downtime, right? So let's think about then how we're paid for a C-section and vaginal delivery. We're generally paid about 10% more. This varies around the country as much as twice as much, 10% more for a C-section and vaginal delivery. Why? Because there's more RVUs for a C-section. Okay, what are RVUs? Where do they come from? RVUs are a measure of the time it takes to do something kind of multiplied by the expertise and training it takes to do that thing. Okay? And I would suggest it takes a little more training to do a C-section than a vaginal delivery, although that increment is relatively small, to be fair. Okay? What about the time? Well, it obviously takes more time to do a C-section, right? Because if you drop the scalpel and then you're sewing up, it's about a half an hour. If you have a kind of a slow intern, 45 minutes, right? A vaginal delivery doesn't take that long. Crowning to delivery, it's like 2 minutes, right? If you have a second degree, maybe 5 minutes. So that just makes sense, right? But wait a minute. When does a vaginal delivery start? Does it start with crowning? Well, I guess you're in private practice and you're at home and the nurses call you when they crown. Then yeah, right? But for most of us, a vaginal delivery starts, well, actually, it starts with prenatal care, to be fair, and that's why we got foolishly duped into doing this global thing, right? Boy, was that a mistake. We made a mistake, my friends. We made a mistake. But here we are. We've been duped in. But it starts, I would suggest, on the admission, or maybe the first time you sent them home to the labor unit, right? When they're late in labor and you're like, no, you should actually go home and let me triage you 3 more times and not get paid for it because it's part of the global, right? Right? That's when it starts. That's when a vaginal delivery starts. It's hours at the bedside. It's checking on your patient and spending time with her every hour, 2 hours. It can go on forever, right? At UCSF, sometimes it went on forever. It at least felt like that, right? A C-section, when does that start? It starts you say, well, let's do a C-section. You go to the OR, you do it, you're done, right? And a scheduled C-section, I've got a C-section for 8:30, you're done by 9:15, you're done. If I have a scheduled induction at 8:30, I don't know when I'm done. It could be 2 days from now. So wait a minute, this doesn't make any more sense. The RVUs from vaginal delivery should be 10 times that of a C-section, right? Because it's all that labor management. And we should probably be able to bill for that labor management, right? Right. That's only fair. So I would suggest that it actually takes much more time to do, and that incentive is a big driver for if you're in private practice and you get paid for every RVU. It really matters that you deliver your patients, just like in Chile. That really matters. And then you add in that medical legal environment. Oh, and I think this is the reason. I don't think this is rocket science. I think this is the reason for our rising cesarean delivery rate. So I've cared about this for a number of years, but I kind of felt like as an MFM, this is really an obstetrics thing. Do I deign to lower myself to just general obstetrics, right? There's not, but this is actually what I'm passionate about. And maybe it's because I got trained by Mary Barger. Mary's here somewhere. Back when I was an intern and she was a young Harvard Community Health Plan midwife. And maybe that's why. But even Sandy Ramos, right, eventually learned to be. So I don't think it's that. I think it's that I've thought about this a lot. I've delivered a lot of patients, and I was agnostic for a long time. I'm a big believer in patient autonomy, and so I thought maybe we should give patients information. They should make decisions. The problem with that is the moment you offer something to someone, it validates it. So I've gone away from being agnostic. I would actually say now I've become a true believer in the goal of vaginal delivery for all patients, right? Does that mean someone with 3 prior classicals should be encouraged to have a VBAC? Does that mean someone that's a breech presenting baby should be encouraged to have vaginal delivery? No, but they should be offered an opportunity to consider risks and benefits. Does that mean that all women who are just walking around pregnant should be offered a C-section? No, because I think it validates something we haven't shown to be beneficial to them and their babies, okay? Other people started to care about this, much to my surprise and happiness, right? So in 2011, I think this was, 2012 was published, 11 I think it was convened, there was an NICHD SMFM ACOG workshop at the SMFM meeting that I got to be part of. It was really exciting. And they produced, Kathy Spong wrote this up. That woman writes like nobody's business, right? I mean, she generates a document every week, it feels like. All incredibly well written and insightful. Anyway, so she wrote this one. And points out that there are all these kinds of indications, so first stage arrest and second stage arrest. So 50% of our C-section, 30% C-section, 50% are due to arrest. Now let's just pause for a second. How did we get here as a species if 50% of our gestations should end in first or second stage arrest? It just seems unlikely, doesn't it? Doesn't it seem unlikely that if 10,000 years ago you were in a band of like 40 people and 50% of your gestations resulted in arrest, such that those babies then end up being stillbirth and then mom died of puerperal sepsis, that we would have survived as a species, right? And of course that's ludicrous. We know that's not true. So this can't be true. This must be overcalled. It just has to be, okay? And so we came up with this list of things. This is table 5 in this paper. This table 5, I think, is the key thing. This is where, again, I think are starting to approach evidence-based management. So one was that if you're inducing somebody, you've got to give them a chance, okay? And that you should wait at least 24 hours after oxytocin administration, preferably in the setting of rupture of membranes, before you call it a failed induction, right? That yes, we do acknowledge that sometimes you have to call it, but man, you should try to get them into labor, and you should be patient to do so, right? Second of all, first stage arrest, that we shouldn't call it active labor until you're at least 6 centimeters dilated. And I'll show some of these data, but I'm sure you know the Zhang data and Leah Alber's data from the late 80s, early 90s, right? And this is from Dwight Rouse, you should wait at least 4 more hours in the setting of adequately documented contractions, and if you can't get to adequate contractions, at 6 more hours. And there's no problem with going longer, right? But at least 4 and at least 6. And in the second stage, instead of 1, 2, 2, 3, which is the current ACOG standards, right? You should wait at least 2, 3, 3, 4 in the setting of progress, okay? So these changes, I think, would impact our C-section rate, and we'll talk about some of them. So what can we do? And we can do these things. Now, none of these things are things that are groundbreaking and new. This is the stuff we've been doing for 30, 40, 50, 80 years, right? VBAC, not so long. VBAC only 20, 30 years, right? The VBAC. But all the rest of these are preventing that first cesarean, turning the babies, being patient. Notice I don't say vaginal breech here, right? I'm not encouraging everybody to do vaginal breaches. I think it's okay to do them if a patient really wants it. But the outcomes technically in the HANA trial are a little bit worse, so I think you got to counsel patients. But at least turn them. They turn, we'll get to that, right? Be patient. If the babies are, even in the mid-pelvis, but certainly in the low station, you can pull them out. It's okay. We've done it for a long time. I prefer forceps to vacuum, to be fair, but even the vacuum I will accede to. It's better than a C-section, I think. Pull them out. Turn the malposition babies if they're OPOT, and we have more OPOT babies because of epidurals, but none of these things can happen without changing the practice environment. So let's talk about the impact of each of these things. Well, VBACs. So the VBAC rate, back in 1996 was about 27%. That means about 40% of women were trying. 40%. What was that number from that study we did? 43%. So we don't think all women want to have a VBAC, but certainly more than 10%, right? What if we just went back to 1996? Now remember 1996. Bill Clinton was just being reelected his second term. The economy was booming, right? It wasn't the end of the world. It was not the dark ages. It was a fine time, right? That's all we want to go back to. 17 years ago, 1996, right? That would be fine. And if we did that, right, given that success, about a 70% success rate was what we see, we would prevent 112,000 C-sections, and our rate would go from 32.8 to about 30%, right? It does not get us where we're going, but it's a drop in the bucket, right? What about breaches? So like I said, I just don't think, unfortunately, I do think that vaginal breech delivery should be featured at academic centers, a place like this, or a place with high volume, as an opportunity. The problem is the number of trained providers that are willing to do it is really rare. So at UCSF, when I was there were 5 of us, and then Russ Relaros really retired and now lives all the time in Hawaii, so he can't fly from Hawaii to do them. Bill Pear decided he didn't want to come in from home to do them, so he'll do this in-house. I left, so the program kind of fell apart. I came to Oregon, we started a program. We have 5 people who come in from home, another 3 people that will do them if they're in-house already, and we take a lot of breech call. But I don't think we do this to lower the C-section rate. It's just to honor, well, the reason we did it actually was to prevent what we call home breaches. So if you think home back is scary, imagine a home breach. And so there was 1 dead and 1 injured baby that had been transferred to OHSU in the 5 years prior to when I got there. And that just felt wrong to me, that these women have no other option than to do a home breach. I mean, it's not that I'm against home birth. I think as long as people understand risks and benefits, right? But a home breach just seems a little bit crazy. So to be fair, right? Remember, even in business of being born, that woman with the breech, the midwife gets her to the hospital, right? I mean, that's the smart way. She's like, oh, no, let's go. We got to go to the hospital, right? So, no, I'm not talking about, but can't we turn them? There's a 50 to 70% success rate. Why don't we turn these babies? You might say, well, of course we do here. But I will suggest to you that around the country, that is not the case. Again, the incentives are misaligned. The RVUs for trying to turn babies is very low. It takes time. If I have a busy clinic and I've got to come over to the hospital and spend all this hour to counsel and then turn the baby, and then turn it away, and then we got to monitor them for that, right? All that time adds up. It's just easier to schedule the C-section. There's no question it's easier to schedule the C-section. And you pay me 10% more, right? So the incentives are misaligned again. Also consider doing one of regional anesthesia. I think that's pretty effective. So this isn't going to be everything, but there's we'd probably prevent about another 63,000 C-sections if we just would vert them all, okay? Or try to vert them all, 63,000. And these are primary C-sections, right? These are the C-sections that if you prevent these, then in the future, they have like a 96% vaginal delivery rate, right? So that's, that prevents future C-sections. Okay, another drop in the bucket. Now what about labor? So labor really matters, right? And you all know this curve. I think a lot of us are trained with this curve. This is a curve by Dr. Friedman. And I think Dr. Friedman's taken a lot of heat in the last decade. Oh, the Friedman curve. Oh, Friedman curve. Oh, yeah. Now wait a minute, hold on. So it's 1953, I think, 52 when Friedman designed the study, right? Nobody's ever published much of any interest, any quantitative assessment of lengths of labor, that kind of thing. And remember that Dr. Friedman doesn't have any computers, right? And so what does he do? He does a study where he studies 500 women in a row, and he has his nursing assistants and RAs, and the residents actually, checking the women every hour and then documenting, in this little notebook, right? It's all done by hand, okay? And then he compiles the data, and it would take forever. I mean, imagine how long this would take. 500 subjects. You have to do all the math by hand, right? If you want to get the average time it takes to get from 1 centimeter to 2 centimeter, you have to by hand add up 5. Now, fair, you had to count. You had some count. They had the abacus, certainly, right? So, right? There's no computers, right? So that's kind of an amazing study in 1955. Is it Dr. Friedman's fault, or I would suggest it's everybody else's fault for saying, "Good job, Manny. Let's do a bigger study." That's a great, what we call nowadays, a pilot study, right? This would be a study that, you have a fellow who's doing a prospective randomized control trial of 200 patients. You have another fellow who's going to abstract data on 500 patients. I mean, that's a great fellow project, right? Fellow project. This shouldn't have been the answer to then manage 4 million women a year for the next 50 years. Whose fault is that? That's not Manny Friedman's fault. That's our fault, right? So, and some people have questioned this. Leo Albers, right, studied, well, maybe the labor curve isn't exactly as Manny Friedman described, right? But most importantly, we know that Jun Zhang has done this work. And Dr. Zhang found this kind of a curve that doesn't have this beautiful kind of sigmoidal shape to it, right? And he found that there's no obvious place, maybe around 6 centimeters, where maybe it gets faster, right? And this gives us the 6 is the new 4 mantra for labor and delivery, right? 6 is the new 4, okay? Now, what about population? So in Dr. Zhang's first study, his patients from the 90s versus Friedman's from the 50s, look at some of the differences. So epidurals, right? And I would suggest, except for on the birth center, your epidural rate's probably higher than 48%. In many places, 70, 80, 90%, right? Augmentation is more common now, right? Look at forceps in vacuum. Now, let's think about that. If you have a 50% operative vaginal delivery rate and you're studying the length of labor, now it's not going to change first stage, but what's that going to do to the second stage? Now, do you remember this commercial for the Tootsie Pop from about 25 years ago? And this turtle wants to know how long it takes to get in the center of the Tootsie Pop, right? And he goes to the wise old owl. Do you remember what the wise old owl says? He goes, how many licks does it get to the center of the Tootsie Pop? He says, 1, 2, 3, right? So, if you want to study the length of the second stage, the way not to do it would be like this. Push, push, oh, baby's not out. Forceps, baby, right? Well, that's the way to have a 20-minute second stage for everybody, right? And what was the median length of the second stage in the Freeman studies? 19 minutes. Right? So I would suggest we didn't actually have any biologic estimation of the length of the second stage from any of the studies prior to the 80s and 90s, right? Because it wasn't biologic in any way, shape, or form. Yet, out of these studies came these kind of magical 2-hour, 3-hour thresholds, right? Based on very little data. That's our fault. So, active phase arrest. So, active phase arrest accounts for about a quarter of C-sections, and it's been classically diagnosed as 2 hours in the active phase of labor, which could be 4 centimeters and above, with no progress in active labor. I heard from my medical students I sent to the Brigham, where I trained, and I love being trained there, that they were now using this large Cook balloon Foley. Now, the beautiful thing about the large Cook balloon Foley is it's really big, and so when it comes out, people are how dilated? 4 centimeters. So those patients, when the Cook balloon Foley came out, if they didn't change in the next 2 hours, they all got sectioned. The C-section rate at the Brigham after the introduction of the Cook balloon Foley went from about 30% to 35% in a 2-year time period. And I would suggest that the majority of that was related to calling C-sections for active phase arrest. Now, somebody's looked at this. So Dwight Rouse, about 10 years ago, said, hey, why do we do this? What if we gave them 2 more hours? I know it's a little crazy, but at UAB, they do a lot of studies, and they're very good at guidelines and protocols. So we created this guideline and protocol and said, why don't we give them just 2 more hours? And what Dwight found in 2 separate studies, one in 1999 and this one in 2001, was that about 60% of the women, if you give them 2 more hours to change, will go on to deliver vaginally, okay? Now, these are women in spontaneous labor. We looked at this at UCSF, and we found the exact same. We found 57% of spontaneous labors. We found only about 35% of those induced. But if you waited 2 more hours, a significant proportion, I would suggest even a third of women having, if you wait 2 more hours, that's worth it, right? So that's the 4-hour, 6-hour kind of threshold stuff, right? So what about that? Well, if it's causing 25% of C-sections, right? If 300,000 women are active phase arrest and you prevent 120,000 or 180,000 C-sections, right? 60%. Man, that's a big drop. 32.8 down to 28.3. That really matters. What about the second stage? Well, right, currently 1, 2, 2, 3. Give them a little hour, another little more time. I would suggest you prevent another 60,000 C-sections. 32.8, 31.1, right? What else happens in the second stage? Well, as we know, operative vaginal delivery has dissipated over the last decade. This is data from Sindhu Srinivas in medical care. This is your rate of vacuums, relatively flat, but here are the forceps. 6 down to basically 1.5% in the country, right? So the sum of operative vaginal delivery has plummeted from about a combined rate of about 12% to a combined rate of about 7 to 8%. And in many centers, it's 2 and 3, right? Well, our residents don't get enough volume anymore, right? So now the thing about operative vaginal delivery is the number needed to treat is about 1, right? Now, I'm not saying let's go back and do high forceps on everybody. I'm not saying that, right? I'm not even pushing mid-pelvic deliveries, which I think are a reasonable thing in the right patient. But just low forceps, outlet forceps, right? Low and outlet forceps, low and outlet vacuums too, right? Operative vaginal deliveries. This is 1992 right here. The high forceps were gone by 1992, right? Most of the mid-pelvic deliveries as well, right? So we're talking about the lows and outlets. That's all that's gone away. And the number needed to treat is about 1. Even in the UK, we're seeing this happen. Even in the UK, where they're like the king of vaginal delivery, the king of forceps, right? Even in the United Kingdom, we're seeing this. This is a problem. And the problem is we aren't training our trained clinicians, right? We have a shrinking pool of providers that are comfortable doing forceps. And again, I'm okay with vacuum. You can tell I'm biased, right? But I'm okay with vacuums. So we've got to refocus the educational agenda. I've got to have someone have practice in a pretty good simulator, having dropped in the blades 50 times before I take them through that one of the 13 forceps they're going to get in residency, right? And we've got to be able to mentor them as junior faculty. So my wife trained with Sandy at Kaiser San Francisco, and she did, I think, 3 forceps in residency. And we actually tried to get her to go hang out with Jim Martin in Tennessee Mississippi, for a month. But then she got pregnant, and so we didn't want her to go there when she was 34 weeks pregnant, and like hang out all night and just do forceps, like on the labor floor, right? So, but when she came to UCSF, we said, she was like, I want to get trained. And so basically about 3 or 4 of us would come in when she was on call and do forceps with her, right? So technically kind of stole that from the residents a little bit, but then she gave back, right? We can do this. There's enough enthusiastic people to keep it alive. We can't lose this skill. Remember, this is a skill set that saved so many women and babies, well, women mostly, back in the dark age, right? I mean, so this is an important skill. Okay, and the research should focus not just on the current pregnancy outcomes. Yes, forceps increases the risk of 3rd and 4th degree lacerations, yes, right? But it prevents a C-section. It prevents that 100-fold increased risk of a uterine rupture. It prevents the recurrent C-section. It prevents DVTs, accretas, previas, right? Longer time horizon. Well, there's a lot of operative vaginal deliveries. We're talking about 10% down to 4.5%. That's 220,000 second stage C-sections. That's crazy, right? I mean, come on. Of all the things I'm about to talk about, that's crazy. Okay. OPs and OTs. So OPs and OTs are more common today because of epidural. There's a very nice study from Elise Lieberman, a prospective cohort study where she followed people through pregnancy, and the ones with epidurals had a higher rate of OP and OT. So we're seeing this more often, and they're associated with longer second stage and all these sorts of things, but mostly increased C-section rates. In a study, in a retrospective cohort study, we found that women who had an attempt at manual rotation, just an attempt, ended up with about a 9% C-section rate. Those that had no attempt ended up with a 40% C-section rate. Now this could be confounded because maybe the women who you really thought they were going to turn were the ones we attempted, right? So that could be confounded. There's no way to control for that, okay? But in an interesting prospective randomized control trial, very small, only 61 patients out of France, to be fair, and the French are really good in the second stage, it seems like. They found that in the group that was attempted rotation, a 0% C-section rate, and the group that were expecting managed a 23% C-section rate. So manual rotation of OP and OT likely makes a difference, just like turning breeches, right? It likely makes a difference. The number needed to avert, about 4. If you do 4 rotations, you'll prevent 1 C-section. Seems worth it, right? Prevent another 50,000 C-sections, right? So those are the things we can do, but we can't do them in the current practice environment. We're improperly incentivized, and we're all worried about getting sued. Now, I will tell you, this is being recorded. I'm just going to say it. So, remember that breach program I told you about? A lawsuit was filed 3 days ago for $25.6 million over the 4th or 5th baby in that breach program that we did at OHSU because the outcome was not good, right? We counsel all the patients. The outcomes are worse for vaginal delivery. You know, what does this make in the hospital? They're like, why are you doing vaginal breaches? Like, because it's the right thing to do. I can't let these women labor at home, but we're in a deep conversation now between risk management and my department, as you might imagine, right? Was this the wrong thing to do? Did I personally cause the harm to that baby? Maybe, right? Maybe she would have just had a C-section, right? We don't know, right? But I certainly do know that the other 19 participants in our program were all planning on home births. And the hit rate is probably not 1%, but I mean, it's high. And so we've got to be able to change the practice environment. If we're always worried about getting sued, we can't do the right thing. We aren't allowed to, right? This matters. Now, lawyers, I will point out, are just human beings. They're human beings. Some of us may be married to some, right? I mean, we have good friends, right? Actually, my best friend is an attorney, right? They're just responding to incentives just like us. That's why there's more lawsuits in states that have no caps on non-economic damages, right? Because the payoff's bigger. Of course there's going to be more lawsuits. They're just responding to incentives, right? So we've got to be thoughtful about how we change our practice environment. And this practice environment matters. Look at the variation by state. The variation by state matters. As you guys probably know, Katie Caughey just published this paper in Health Affairs last spring, and the variation in their data set was 7% to 70% for C-section rates. Now, I probably, if I'd showed this data, I probably would have gotten rid of the tails because I think it sounds so crazy, right, 7 to 70. But even within the kind of clear distribution, it's kind of 15 to 50. And this is probably real, right? There really are places that have 15% C-section rates. They really exist, not just birth centers, real hospitals, right? And there are real hospitals that have 50% C-section rates, which I'm sure you know, right? So if there's such variation, economists say, wait a minute, and health managers say, wait a minute, this variation can probably be controlled to some degree. So we're going to be, if we don't fix it ourselves, we're going to have administrators fix it for us, which I'm not sure we want to have happen. you can change the practice environment. Hospitals and laborists. So this study shows that in hospitals that have 24-hour labor coverage, the rate of C-section appears to be lower. Now, that could be an environmental thing, but it does make sense that if you know there's someone around and it's safe and you can be patient, you're less likely to do a C-section. If you know you don't have anesthesia in-house, you're more nervous, so you call people in. Now they're watching you. So when I used to moonlight at St. Luke's, a small hospital in San Francisco, to do a VBAC, we had to call in the OR team and the anesthesia team, and they would basically page me hour after hour saying, how's she doing? Because they wanted to go home. I'd be like, oh, she's 4 still. It'll be a long time, you guys. You might as well go to bed, right? That's hard, right? A lot of pressure, a lot of disincentives towards being patient. So this stuff's mostly conjecture. I don't know what we can do. I know you guys have a doula program. There's good data from having doulas, people sitting at the bedside that lowers C-section rates. What if we were paid to be patient? Now, one of the things we do in labor, especially if in a continuous fetal monitoring, is we actually every hour on the hour are doing either an NST or an OCT, right? What if we billed for those, right? So your obligation was actually go to the bedside and look at the fetal artery tracing every hour, and then you talk to the patient and you'd bill for it, right? That seems like that would incentivize you to actually be patient in labor, right? You get paid to wait 2 more hours, right? Maybe that, I don't know. I'm just, I'm just a crazy guy, just talking with ideas, right? We gotta do something though, right? So we gotta think about this. At least we should be paid the same for vaginal delivery. Now, one way to fix this is capitated reimbursement, right? So if we're capitated such that the hospital plus the doctors and the clinicians, LIPs, receive one amount of money, say $5,000 for everything, including the hospital stay, and all of a sudden the hospital's gonna be like, oh, wait a minute, it costs us $8,000 if you do a C-section, but it only costs us $3,500 if we do vaginal delivery. Don't do C-sections, right? So maybe that will affect things. We'll see. And it's always, I don't like to wait for incentives to fix things. I like to be able to fix it ourselves as providers to do the right thing for the patients. But this is what happens when we don't fix it ourselves. So yeah, I mean, if you look at the paper from Harvard, maybe you prevent another 50,000 C-sections if you change the caps thing. It doesn't matter, because all the other stuff we talked about, we can't do unless we change the caps, right? And if you added all that stuff up, you add it all up, and you'd get down to a C-section rate of 15.6%. This isn't 1973 when it was 3%. I'm not talking about high forceps or vaginal breaches, I didn't talk about any of this stuff, right? This is just common sense kind of stuff that we should be doing, right? And we can have a C-section rate of 16%. I know that's not likely to happen in the next 10 years. I acknowledge that. I'm not that crazy, right? But we certainly can do what we did in the early 90s and slowly march backwards. We've leveled off. Why can't we go down? Break 30 again, right? It's going to take a while because there's a lot of people who got those primary C-sections already that can't get VBACs, right? We can encourage places to think about ways to do trial labor. So there's a guy named Pete, I can't remember Pete's last name, who became the chief of obstetrics at Natividad. Natividad does about 3,000 underserved patient deliveries. They didn't have a VBAC program because the anesthesiologist wouldn't be in-house. He said, I will come be your chief of obstetrics if you allow me to start a VBAC program. And he did his first 50 VBACs in 2010. They did another 100 the next year. So it's possible to bring this back. It's not that crazy. And I know it seems crazy from some people's perspective, but I think in this room we don't think it's that crazy. So we can do it. That's the end of the talk. I'm happy to answer any questions. I know we're a little bit late because we started a little late. I apologize. But again, thank you so much for having me, allowing me to talk about the thing that I end up being the most passionate about right now in my career, other than my department, who I'm very passionate about. Thank you so much for having me. Appreciate it. So, questions? Dr. Resnick?
I thought that was outstanding. Can you hear me?
Yep.
And a lot of the points are so well put. Remember when the cesarean section rate was 2%.
Right.
And the outcomes, other than the babies dying. Thank you. The outcomes, other than the very preterm babies dying, were basically the same as they are now.
Yes.
And I've mentioned many times that I can't find any evidence-based data to support in terms of maternal or fetal outcome that increase in cesarean section. That was a statement. That was my question. Here's my question. In terms of the causes of the increase, I was surprised that you didn't mention electronic fetal monitoring. Want to comment on that?
Yeah, so I think electronic fetal monitoring increased the cesarean delivery rate in the 70s and early 80s. I don't think that the rate of continuous fetal monitoring changed much in the 90s. And so that's why, I don't think that continuous EFM is going to go away in the majority of the US. I think that as more hospitals realize that the cost of birth can be minimized with things like birth centers, there might be a pushback to intermittent monitoring, that sort of thing, because I think you're certainly right. But I'm just looking at that rise from 96 to now, when there really hasn't been much introduction of new technologies, right? There's no question that when you look back in the history, in the 70s and early 80s, I think that the getting rid of high forceps and, of course, the electronic fetal monitoring was a huge impact. And what's interesting about, of course, EFM is that we probably understand how to read EFM today about as well as we did in 1978. And I'm sure some of you are much better, but honestly, as a system, and because to be fair, when we went to the 1, 2, 3, the category 1, 2, we take a huge step backwards. It was a necessary step to say we actually don't know anything about these category 2s, which are this huge range of tracings, right? And now we're starting to do the research that should have been done back in the 70s. So I agree with you about EFM, but I don't talk about it because it really is, I think, a before the 90s kind of an effect.
Also enjoyed your talk. It was great. I used to do C-sections if they failed to progress at 4 centimeters for 2 hours.
Yep.
And our rate was 12%. So I'm wondering if we let them go longer. So I think that we need to do that waiting longer to get maybe backwards numbers, but I can't buy it as a cause of the rise. One. Number two, I'd like you to comment about your paper I saw this month, that if we induce between 37 and 40 weeks, we can lower the cesarean delivery rate. Thanks.
So the very first time I gave this talk, I had induction of labor as one of the things mentioned about ways we might be able to lower the C-section rate. And for those of you that don't know the stuff I've written on this topic, you're probably like, wow, we really like this guy until about now, right? So I can appreciate that. So my early work was I was interested in studying kind of what happens at weeks of gestation at term, 36, 37, 38, 39, 40, 41, 40, right? That was kind of the work. And I came up with the fact that it looks like, and I give this talk about the cookie, about the optimal gestational age to deliver a cookie, which is like about 39 to 40 weeks, right? And so then when you come to that, you're like, oh, well, how do you prevent the stillbirths that happen at 40 weeks, 39 weeks? Well, the only way is by getting the babies out. And so then we started studying induction of labor. And so when you look at the literature, right, there are 9 well-done prospective randomized controlled trials at 41 weeks of gestational age, and the summary odds ratio is there's about an 18% reduction in C-section to women who are induced at 41 weeks as opposed to expectant management. There are 3 prospective randomized trials done before 41 weeks. They're all small and not in this country. One is in France, published in French, so actually I couldn't read it, but I could look at the table, the Bayards paper. And the summary odds ratio, which is in the Cochrane review from like 2009, 2010, is 0.67. There's a 33% reduction in C-section for women who are electively induced prior to 41 weeks of gestation as compared to expectant management. One of those papers was published in Lancet in 1975. So that made me like scratch my head, and I thought, well, why is that? Why is it? I'm like, well, we all know that induction causes C-sections. Every day we're on the labor floor, we see those patients, they are induced for days and they end up with a C-section. So we know the spontaneous labor patients come in and they deliver, right, vaginally. Well, there's a problem here with both the availability heuristic, but most of the comparison of proper groups. Because as a clinician in your office, you have someone in your office at 39 weeks of gestation. Your option today is not induction versus spontaneous labor today, right? It's induction today versus expectant management. Well, what is expectant management? It means you go off into the future. What happens during the future? Well, 2 things happen that increase C-sections. One is babies get bigger. Babies gain 220 grams a week, and so a kid that was 3,800 grams at 39 weeks is going to be 4,020 at 40, at 40, and 4,200 at 41. The other thing is placentas get older, right? And we heard really nice work. Doug Volkers was talking today at Rounds about PLGF, and I really think I'm hopeful that we'll come up with a really good maternal serum measure of placental function that we can use to identify the failing placentas and basically induce those patients, because you can't induce them all at 39 weeks, right? I hope. So when you actually compare the right groups, which is those induced at a particular week of gestation to those expectantly managed, you find in our first paper in the Grade Journal in 2006, a subsequent paper by us in 2010, and then the most recent paper in the Green Journal this month, that the effect on C-section is at worst no difference and potentially decreased. This has also been looked at by Chris Glantz, by that Stock in the BMJ last spring, and Grobman's group. And they found 2 of those papers found no difference, and Stock found a reduction in C-section rate as well. So there may be something there. And now the MFMU like this, and again, it's maternal fetal medicine units, they think this is so important. They've fast-tracked a study, and they've started now an elective induction of labor versus expectant management study between 39 and 41 weeks of gestation, and so we'll be able to have somewhat of an answer. I don't think that the answer, that is the way to prevent C-sections, honestly. I think that figuring out outpatient ways to encourage the onset of labor would be a great way to go. So stripping the membranes, encouraging vaginal intercourse if they have a male partner. I mean, even if they have a female partner, orgasm may ripen the cervix. We don't know. It'd be nice to do the research. And figure out outpatient ways. Outpatient cervical Foley bulb. I mean, but it needs to be studied. And we just have spent such little time on it. There's no big money to be made. So we don't have like big investments in this work. But thank you for the question. And sorry for induction of labor causing decrease in C-sections. I didn't want to believe it either, but it kind of makes sense when you think about it. Good. Okay, we'll call it a day. Thank you so much.